It's Dr. Tofi. Welcome to HerniaTalk Live, your weekly session with me, Dr. Tofi, your hernia and laparoscopic surgery specialist. Many of you are joining me on as a Facebook Live, and thank you to the rest of you that are on Zoom. And as you know, you can follow me on Instagram and Twitter via @HerniaDoc. And at the end of this show, as well as all previous episodes, you can see them and watch them and listen to them on my YouTube channel @HerniaDoc. So today is really a great session. I love having our European surgeons as part of our HerniaTalk Live sessions. It's a special session today because it's earlier in the day, because it's like 10 o'clock at night in the United Kingdom. So I would like you all to very much greet and thank Dr. Maciej Pawlak for joining us from the United Kingdom. You can follow him on Twitter @Maciej Pavvlak. But let's just say hi to Maciej. Hi.
Hi, Shireen. It's great to be here, and good afternoon or good evening to everyone who is joining us. It's a real pleasure and an honor to join you for Hernia Talks.
Oh, it's for sure my honor. So those of you that are on HerniaTalk.com, which is the website that started all of this, it's like a free patient discussion forum. They talk a lot about groin pain, postoperative hernia related surgery pain. There's a lot of confusion. It's because they're sent to urologists, pain management doctors. Some of their surgeons don't know what to do with it. And then they talk about stuff that we talk about. So just so you know, Maciej, my audience, they go to YouTube, they listen to the talks, they know what the lectures are planned for at the European Hernia Society meeting. They're very educated when it comes to all the stuff that we do. Like they knew the agenda for the EHS before I knew it. They were posting about it. So you gave a great talk this last year, actually. Your talk at Manchester was really great. There's a lot of talk about chronic pain, multidisciplinary treatment. You've really been at the forefront of that and brought in your own experts that you use. So I was hoping that we could spend the majority of our hour learning about, first of all, I'm very curious your story. Like, how did you actually get involved in this? Many people know my story. Mine was it was happenstance. Very happy with my decision to be a hernia surgeon and deal with these complicated situations, but I'm always curious how everyone else got involved in the care. So tell me your story first.
Yeah, well, like every good story, it starts up with a bit of luck, a lot of commitment, a lot of work, and good mentorship. So I was very lucky that since the beginning of my career, I had unbelievable mentors, and because I really love abdominal wall reconstruction, I love anatomy, hernia, and difficult, those difficult parts that we sometimes have to deal with as surgeons, as doctors. That led me to meeting people who who were on the forefront of hernia surgery, on treating of chronic groin pain and abdominal wall reconstruction. And I had the pleasure to learn from them. And, we are hernia family. And also patients should know that we work as a team. We're a great team of people from US,
yes,
from UK, from all over the Europe, because we are passionate about what we do. And we actually want to deliver that excellent care to our patients. It's just, and that's why I'm joining you here, because I think we need to get to patients with that message that there are surgeons, that there are people out there who want to help them. They have the ability, they study that, it's their, like jewel in the crown, that they can actually figure out what's going on and offer some support and help.
100% agree with that. Part of the reason why I do this is because I'm trying to bring out to the public all the specialists that I know can help them, because they're like, I live in such and such place. Who can I see? And I say, go to HerniaTalk.com or look at the episodes, and you'll see surgeons in your area potentially or nearby that can help you. And Europe especially, I would say, has great hernia surgeons, but in the chronic pain, complicated revisional, especially groin revisional situation, we don't have that many surgeons like you. You feel that?
Well, that is unfortunately true. I hope it's changing now. So we've started a new collaboration together with my colleagues from Netherlands, from Denmark, from UK, and we are sharing our knowledge. We are thinking about what's the best protocols, learning from our experience, from our mistakes as well. And hopefully we can coin that into better knowledge, better research, and I think it will grow. Obviously, in United States you have like excellent experts. I learned most of the things from David Chen, so he is my great mentor, and I'm very happy for everything that he shared with me. I've spent so much time in LA, and it's just incredible that you can learn from people like yourself, David, and other mentors out there.
Absolutely. And he's very generous in going around, traveling all over the world, teaching other surgeons.
Yes, and and now with the sessions, as you mentioned, in Manchester, which was solely dedicated to chronic groin pain, with sessions dedicated to patients. We I'm part of EHS, and I've been a part of EHS for more than 10 years now. And we are changing as well. We are more patient oriented. We include more and more patients in our meetings, and we find that it's such an important voice, and therefore there are more topics about complication and things that might go wrong, and where to seek help then.
Yeah, and I think the more you engage the patient and the patient point of view, the more you understand that maybe the message you're giving out is not necessarily the right message. I'll give you an example. I think is it hernia surge or the EHS guidelines, which promotes laparoscopic inguinal hernia repair with mesh as the standard best option for women, right? Because it allows you to identify a femoral hernia and treat it at the same time. Sounds very reasonable. But then if you think of it from a patient standpoint, that means every single female will get a mesh-based repair. I'm not sure I agree with that. I don't agree with that. And maybe, and I understand they're now, because of this feedback, they're considering tweaking that recommendation, saying, you should always rule out femoral hernia, period. Laparoscopic repair with mesh would be the ideal way to address it, but not all women need to necessarily have that repair. So it's, if you think of it from a patient standpoint, they kind of say like, wait a minute, I don't want mesh in me, and yet the guidelines say I must have mesh. Then you start thinking, okay, well, our message may not have been the right message, even though the intention was to improve care, for example.
Yeah, guidelines is a tricky bit of our work and of our research. I am part of a few guidelines projects, and they are dedicated to the majority of surgeons to guide them. And it's it also helps to have that discussion with patients, to start that discussion, because then at least in one place you can find information about the occurrence of the problem, options of treatment, what are the current standards, what are the evidence, and what sort of evidence are out there. Obviously, in a lot of topics, we don't have, first-class evidence, unfortunately.
Yeah.
And we sometimes need to go with experts' opinion and what's best. And then I think our role is to discuss with patients. Those are your options. Guidelines guide me to offer you laparoscopic surgery, but obviously, if for example you can perform an ultrasound scan, exclude femoral hernia, and then it's a patient that could benefit from tissue repair, and
exactly.
understands the differences, the risks of both surgeries, you make that discussion. Obviously,
Yes,
you have to be dedicated hernia surgeon at that point to offer all those
right.
surgeries.
Yes,
And we're going to guidelines where they are guiding the majority of surgeons, not hernia experts or hernia enthusiasts as ourselves.
yes. So so you did your general surgery training, and then how did you fall into hernias and now chronic pain and kind of revisional complex patients?
Yeah, so my history started in Poland. I'm actually from Poland. I've only emigrated to United Kingdom 5 years ago for a fellowship, and my career started in Poland where I did a PhD on intraperitoneal meshes, and like I've did randomized control trial that compared Physiomesh with ventral IST, and after that we showed how the results of those surgeries that then triggered to pull out data from Danish and German database, and it pushed off Physiomesh out of the market. So that's started and triggered my career. And
historic event.
yeah, actually it was, yeah. And I went for a fellowship in Edinburgh with Andrew DeBow, who is abdominal wall reconstruction surgeon. And what was missing there in the service was actually chronic groin pain. Mm-hmm. And because I was considering staying there and in United Kingdom, I wanted to fill up that gap. I had a bit of knowledge before because my boss from Poland did some surgeries. And I remember, in the beginning, I was a very young surgeon, and I've seen preparing to surgeries for the next day that there was GPS, it was called, like GPS surgery. And it's like, what's that? Like, I tried to, it wasn't the time that you could actually Google those things. I had
Yes.
wanted to look for what sort of surgery it is. I couldn't find it because nobody did that. So I asked him, like, what's GPS? And he said it's groin pain syndrome at that time. That how it was called. So I did a few surgeries with him, and I've seen, how difficult it is, and how we don't have established protocol for that. So later on in Edinburgh, I really got interested. I've started to talk about it with David Chen. I've went for shorter fellowship to LA. I've seen Ralph Lawrence, that was your guest as well, and learn pure tissue repair. I visited in Hamburg Henning Niebuhr, who taught me how to properly ultrasound scan groin, because I knew that if I were to go in that direction, I need to offer the whole package. I can't say, I only do that. I need to know what I'm dealing with, especially when you talk with those patients and you try to find out what's going on. You have that, if you have that ability to do an ultrasound scan, show them what's going on and what possibly is not a problem. That's so helpful, and you're like so ahead. You gain their trust as well, because how not to trust surgeon who is actually interested, who knows the anatomy, knows what's going on, and can show you, like, this might be a problem, that's definitely not your problem, you don't have recurrence, and so on and so on. So step by step, I was gaining all those skills that put me in a position to actually start, because I think that's the most tricky bit, like from hernia surgery, is actually deal with complications. Complicated patient, complicated history,
especially in the groin.
Pain.
Yeah, especially in the groin. I enjoy the groin. I think the inguinal region is fascinating. I learn a lot. I love that I get to work with other specialists as a result. But most people don't, they do a lot of abdominal wall, but the groin is kind of like not their thing. I like it though.
Yeah, I love it. But you have to really have the knowledge to love it, because patients, they usually have seen so many people before, and they need to trust you, and so they can trust you. You actually have to earn that trust, and you have to earn that trust by knowledge, but by having that knowledge and being compassionate, understand what's going on. And you can only understand it if you actually do learn it and do understand it.
Yeah, our friend Hakan is watching us live. So hi, Hakan. He's saying, when you're an expert, then the chronic stuff kind of, they get attracted to you, and then they kind of stick on you. So yeah.
Yeah, Hakan
He
does
understands it.
an amazing job in Europe as well. He's promoting our society, but also, those talks as you're doing in the US. He's our guy in Europe. So Hakan, great job, and thank you for joining us.
Okay, here's a live question. It says, is there any way to distinguish whether chronic post-inguinal hernia repair pain is neuropathic or mechanical? And does it matter in terms of the management?
Yeah, obviously it does. It's actually main part of our job is to find out what sort of pain it might be, and then figure out what might be causing that pain. Obviously, neuropathic pain is that's the major issue. Well, that's the issue in most of the patients with chronic pain, and it's due to the nerve damage or nerve involvement in stitches or mesh, whatever. It's connected to nerves. And there are signs, there are symptoms that help us distinguish that. And the other pain on the other end of spectrum is nociceptive, that mechanical pain connected to tissue involvement, tissue damage, mesh, chronic inflammation connected to mesh, and so on and so on. But usually patients that come to see me, they do have both component of pain. It's not that simple, and because it takes time, so in the beginning it might be just a nerve entrapment, but you have to imagine that with time it's becoming a persistent pain cycle. So it's not only that neuropathic pain, all the messaging that comes from that area to your brain, that's being changed because your brain and your body is trying to deal with that situation. And obviously you have to deal with the stress, you have to deal with your quality of life, which is debilitated, and so on, so on. So you enter that pain cycle. So it's not, it's not that simple that, we find that nerve and we'll deal with that and everything will be fine. No, it's need to be holistic approach. We need to obviously find out what was the main issue, but the treatment is of a patient, not only of that issue.
Talking about neuropathic pain, do you feel that people get nerve pain after hernia repair because it was somehow injured at the time of surgery, or is it later on due to like scar entrapment or mesh related reasons?
It can be both. When you look at the risk factors of developing chronic pain, obviously very high intensity of pain straight after surgery, that's a huge risk factor and should be a red flag for everyone. If somebody is waking up from surgery and they have horrible pain that you can't resolve with any painkillers, like the baseline painkillers, that means that something is not okay here, and probably that patient should go back to theater and should be explored. And that happens. Like, this is surgery. It happens to every surgeon, no matter how big an expert they are. We can't see everything and we can't predict everything. And you can catch, you can be very careful, but there are main branches of nerves, but there are also small branches of nerves, and we have to fix it. It is surgery. We are fixing a problem, whether it's with mesh or with pure tissue. Does involve stitching it with permanent stitch. So that stitch can also catch a nerve and can cause problems. So, I want everybody to also remember that it's not only the mesh that's the problem, it's the problem of surgery. And, those things can happen. But
it can happen without mesh,
when there is a problem straight after surgery, severe pain, that means that something's wrong. Obviously, later on, it might happen in a later healing process, as you said, with creating of scar tissue. For example, I've noticed in laparoscopic repair, we use tackers. Obviously, now we are more cautious with using tackers, but earlier, because we also learn from our mistake, and we need to be honest about that. But earlier we just fixed the mesh because that was the way to do it, and we wanted that to stay in place. And I have a lot of patients that actually develop like chronic neuropathic pain when they, for example, lean over something, and
Yes, well,
then
they're
the
brushing
packer
their
is pushing on the nerve, and
yes.
they have like this pain only then. And, you know, like for me, it's then simple. I say, yeah, I know exactly what's going on and what I need to do here. You know, that's
Yes.
simple one.
Yeah, when they're leaning against their sink, you know, to brush their teeth.
Yes, exactly. That's the
typical one.
typical.
Or washing dishes. Yeah,
Mm.
that's the one. Because the groin is right usually right at the level of the sink or table or something like that.
Yeah.
Here's another live question. It says, I have post-operative pain for 1.5 years. My pain management specialist says my risk of developing chronic regional pain syndrome, even from revision surgery that is remote from previous surgery, is prohibitive. Are there ways to predict the effectiveness of a reoperation as opposed to just further aggravating and activating nerves, making the pain worse? That's a very good question. I don't know if we have the answer to know how to predict that, but what do you tell your patients that have nerve related symptoms and
So-
you may want to do something to that nerve?
Yeah, I agree with you. I agree completely. It's a very good question, and it's a one that will struggle to answer probably for a long time.
Yeah.
Because we need more data, and currently we don't have that data. What I usually try to do is, first of all, find out what's going on, and then have a clear plan and discuss it with my patients, and, you know, also taking into consideration the current quality of life and what they cannot do, and how big the surgery might be. You know, if it's a simple surgery, you know, then it's a small damage, and it should be, you know, more or less fine after the surgery, after the healing finish. But if it's a large surgery with mesh removal and neurectomies, that's a huge injury to already injured groin with complex pain syndromes. And we now tend to go slightly other way. We try to desensitize the groin first with some physiotherapy, medical therapy, injections. So when actually we go in with surgery, you know, those neurons that are responsible for triggering that pain from the area, it's already numb, and then that surgery itself and the injury that we cause won't create even more pain.
Yes.
But, you know, we can't predict it. We can only think that that's quite reasonable and it works in our patient because we have good results with that. But, you know, I say I can't promise anything to anyone because I don't know. Like, I don't know what the future will bring. I have only my ideas based on my examination, based on my findings, discuss it with patients, and if they are happy with the plan, I will go forward with the plan. But, you know.
Yeah. Well, yeah. I mean, anytime I manipulate or cut a nerve, I numb it first. It seems to help reduce any post-operative nerve-related reactions. But so we looked at all the nerve transections that I've done, all the neurectomies that I've done in the groin, actually anywhere in the body, mostly groin. And we looked to see the outcomes of it. And we found in patients that had nerves cut incidentally, like I wasn't going in there planning on cutting the nerve. Let's say the nerve was stuck in scar or somehow it wasn't their main problem, or was done for some reason prophylactically. They all did okay. I didn't have any problems with those patients post-op. However, in the patients that had chronic pain, neuropathic pain, maybe a neuroma, that I went in there specifically to surgically address the nerve, we had a 4% neuroma rate after that. And that's pretty much the same as other literature, which is like, I think 5% in other literature. So that's about similar. And then these people needed like more procedures and so on. So then I'm trying to look at the literature to see, okay, that's surgical neurectomy. What's the neuroma rate from ablation, right? So whether it's chemical ablation, radiofrequency ablation, chemoablation, cryoablation, etc. There's no literature on it. What's your experience? Do you think there's less neuroma risk or less like even complex regional pain syndrome risk with percutaneous procedures than surgically cutting a nerve? I don't know.
I think, we won't get a good answer for that as yet. What I think is what you mentioned already, that the procedures that we are currently offering are the procedures that are damaging something anyway. So neurectomy, let's be honest, that's basically damaging the nerve in a different place that it's been already damaged under control. So we control how we damage that nerve, and we know that we can, if we bury that in muscles, it's probably will be protected. But we don't know like what will happen. It might develop neuroma. It's we'll make the area numb, and obviously it shouldn't trigger all those pain sensation. But it's like with amputation, we all have phantom pain as such, and some patients will need further medication. So yes, we start with less invasive procedures and follow that with more invasive procedures. So I would start with radiofrequency ablation in every single time. And it's good to have different plans, and it's good to discuss it and also make it realize to our patients that we are not doing any magic tricks. It's not like that pain is gone. No, it is a process. And we want to be part of that process, help you, guide you, create that individualized plan and follow that. And you might be fine for 2 months, 6 months, then something might come back, then where to find us. We'll follow up. We'll try something different.
Just to clarify, the question here is asking, when you talk about desensitizing nerves before any procedure, is that with medication, physical therapy? What exactly are you offering the patients?
So it's a combination. So that's probably the main topic that we'll discuss today is the MDT approach. So it's not only me. I'm currently the face of the service, but it's like all the enthusiastic people that are working with me, together with me, and we create a team. And when I talk about desensitization, definitely it's physiotherapy, and we have an amazing physiotherapist who is a pain physiotherapist. He also had an amazing lecture in Manchester. We have our pain specialist that is dedicated to this sort of pain, and also looks through the medications that those patients were taking and try to tweak it a bit, and also use, for example, radiofrequency ablation as a part of desensitization. So there are stuff that I don't even know and don't understand as a surgeon, because there are like ice packs, there are different topical agents that you can use for desensitization. So it is multidisciplinary thing. So whenever we come with a plan, it's from different people coming with different background, different knowledge, and that's the beauty of it.
Okay, there's some more questions coming in. Before we go to those questions, maybe explain to me your multidisciplinary treatment. Do people first see you, and then who are the other specialties that encompass your office or your center? Yeah.
So again, it's the enthusiasm and pure luck. So I had that vision in my mind that it would be good to have everybody in one room examining the patient.
Ideally,
because then we can discuss and we can share our opinions and find out what's wrong. It's like really, it's like almost being a Sherlock Holmes and having a team of real experts that will look and try to figure out that puzzle, because it is a puzzle. Very often you have to have so many information in, based on what sort of mesh was used, what sort of suturing material, like hackers, where was it done, and a lot of things will help you and guide you to find the answer. And so I was thinking, who should we involve? And usually, if any patients are listening to us, where are you usually referred to? Pain specialist, physiotherapist, to some sort of physiotherapy or psychologist also to discuss other issues, and obviously surgeons. So the core of our multidisciplinary team is surgeon who can help surgically and can actually look at the previous surgeries and gain some sort of understanding what might have been done in the groin, what might have triggered that pain. We have pain specialists that also bring in all the equipment based with pain specialization and anesthesia. So medications, radiofrequency ablation, injections, and so on and so on. And then physiotherapies, but I always consider like physiotherapies as physiotherapies. It's obviously musculoskeletal is a big part of the problem quite often. So that was my thinking, and I was so wrong. And that's what I learned in North Devon from our team, that there are dedicated pain physiotherapists that also discuss with patients their concerns, expectations, actually find time to discuss what's important to them, what stress factors are involved. So it's more like psychologist, but it's just genuinely nice person, very compassionate person that, whenever we discussed on MDT, and I gain knowledge from patient to patient, and I think I'm getting there and trying to get more information out, but he will always bring something new like to the table, and so important. I'm like, oh yeah, I would never ask that, I will never notice that this is the problem. And we need to, because it's a quality of life, but patients also have expectations that they usually don't discuss with us, because we don't ask about their expectations, because we are so focused of what might go wrong or what we might change that we don't think about it. And I think that's the most important questions. What are your expectations from coming out of this office? How can we help you?
Question on Facebook is, what percentage of your work is actually surgically removing mesh, as opposed to all the other different ways of helping these patients?
So we haven't published our data yet, but hopefully we'll publish them soon. I have my team working on that. We did present our data in Barcelona, in the AHS Congress, and more recently in ASGBI Congress in Harrogate here in UK.
That's a great meeting, by the way.
Yeah, and so actually, it's only 25% that will have surgery. And this is comes as a surprise to a lot of people. 25% will only need surgery. 35% will need further non-invasive procedure or less invasive procedure, like radiofrequency ablation, and also medications and therapy with pain specialists. But the majority, which is, I think it was 39%, or something around that, needed support, needed physiotherapy connected with pain medication, and basically needed that understanding that we can offer, and that compassion and understanding of what might have happened. And it helps, trust me, it really helps if you're listened to, if somebody can understand, and even hearing that surgery won't help you or might get you worse, but we can help you get where you want, listening to your story, that's helpful as well.
So how do you handle the patient that comes to you and says, I want my mesh out, I've been miserable since surgery 2 months ago, and I just want my mesh out? And then you end up switching the discussion to be, let's make sure we're dealing with this non-surgically, and it's not, the mesh is not your problem.
I'm actually a horrible person. I often will argue with my patients. Like I want to help you. Like if you come to me and tell me what I need to do, like I can't do my job because if I do it, I know that you'll come worse off, and that's against my my aim, my practice, and everything that I believe in. So we have that back and forth, and we then start to discussing what's going on, what's the story behind that, and very often after you peel that first layer of take my mesh out, you hear the story of seeing multiple specialists, being in horrible pain, debilitating pain, not being able to work, not being
Yes.
able to be active, gaining, horrible stories. And you just peel another layer, and you come to some sort of consensus what has happened and where are we going. And especially in those complex stories, you have to deal with that story first before you will deal with the groin. So I'm never saying no. I will never say no to my patient that I won't take your mesh out. I just do it on my terms. I need to find out what's wrong and what's the best way to help you. And you came here to me, and I hope you appreciate that I have my opinion and I want to share it with you, and then we can discuss it. And obviously it's your body. You'll need to agree to what I'm offering you.
What kind of patients do you think most benefit from this multidisciplinary approach? Is it for everyone? Or do you think there's some personalities or problems that don't need it?
Yeah, we're trying to find out because it puts a stress into the service as well, and to everybody involved. You can imagine that we can't run that clinic every week because we have our busy surgical schedules, we have other patients, and so on, so on. So it's very limited access to that multidisciplinary clinic. And therefore, we need to triage those patients properly. So we try to find out if it's not an easy fix, because a lot of those problems are easy fix. It's like just you need to look properly, and you'll find what's wrong.
Could be
so
just
we reserve
recurrence.
that to our most complex patients, where we want that solving the puzzle from different angles. We hear from the story it's more complex. We see that there were already multiple attempts of doing something, nothing worked. And basically, when I need help, when I see I need others also to look at that patient. I need their opinion to make a good plan for that patient.
Question about capsaicin. What are your thoughts about 8% capsaicin as a way to desensitize the groin?
Yeah, I know that we use it. I know that our pain specialist does use it and prescribe to some patient. And I'll be honest, I'm a surgeon. That's why we work in multidisciplinary team, because that allows me not to know everything. And even I will ask that question. What do you think about that? And because I asked that question, I can answer like we don't have good data. And it's the fact, there are multiple medications out there that we are trying in combination with other medications, and that they somehow work. And I know it's horrible to be a patient and hear that, we'll try this or that and we'll see how it goes. But sometimes it is like that. We need to try different things. Some things will work for some patients, some things won't. And definitely we are using that drug in our but I can't answer to which patient will benefit the most from it.
We have access to CBD and THC, which tends to help with some inflammatory pains and a little bit of nerve pains. Is that legal in the United Kingdom to use marijuana? Or THC, CBD
I think, I don't know. To be honest,
it really helps.
I'm not sure. I won't lie. I know that it's becoming it's definitely a popular way of treatment in Poland, for example.
Okay.
But in United Kingdom, I didn't encounter it. I don't think it is.
Yeah, I don't think so either. Here's another live question. How long do you usually wait before trying triple neurectomy if this patient still has pain?
So
Well, let me ask you another question.
we are going.
Do you believe in triple neurectomy or selective neurectomy?
So I believe in both. It's funny. I like to find out what's going on and then discuss the options.
Okay.
So
Sure.
the protocol that we have is we wouldn't go straight after surgery before the whole inflammatory process and healing process finishes, and that's like 3 to 6 months. And usually, after 3 months, you should start on something, but that would be usually medications, because you want to aid the natural response of your body, of your immune system, and because probably something is going wrong if you have pain for more than 3 months. But first, you just aid your own body. Our body is amazing, like it can deal with most of the problems. If pain persists for more than 6 months, that's probably when we should assess what's going on and find for a different way. So I wouldn't do neurectomies definitely before 6 months and before a proper assessment. So it's not that it's not elective surgery that somebody will send me somebody for triple neurectomy. No, it's a dedicated surgery for the patient who understand the risks and benefits and actually had a proper assessment.
When people come to me and they say, I don't want Meshoma because I don't want chronic pain, and I explain to them that, that's not necessarily the right answer. It depends on the patient. But if you want to take all hernia repairs put together, probably the laparoscopic approach will give you the least chance of chronic pain than in any open approach with mesh or without mesh. But in my area of town, we're seeing a lot more people offering not just laparoscopic, but specifically robotic hernia repairs. And I feel like they're doing it because the robotic technology is being pushed a lot, and they don't want, it's like a fear of missing out, and they never really did laparoscopic before. So I'm seeing a lot more MIS, robotic mesh repairs gone wrong. So I can't in good faith say go anywhere and get it done because the outcomes are not the same. So I'm getting a lot more chronic pain, even a lot of spermatic cord injuries, etc., from laparoscopic or technically robotic repairs. Are you seeing that as well?
We are only catching up, and that's probably good.
It's not pretty. Don't catch up too fast.
And it's not easy to use the robot in or gain access to robot in Europe. Colorectal surgery, obviously urology, where we know that there are clear benefits of that aid, because let's be honest, that's an aid to your surgical knowledge and to your skills. It just helps you do the things that you wouldn't be able to do otherwise. Okay. And we can do laparoscopic inguinal hernia repair. Like that's a simple procedure. Like in most of the cases, if you know what you're doing, like TAPP or TEP, that's, you just need to know 10 commandments of how to create MPO, Ed Felix, Jan Kukleta. You have the experts, you have EHS, AHS, you have places where you can learn proper surgery, and you can do it laparoscopically. Obviously, robotic does allow you to do more difficult cases. So, for example, if I were to choose mesh removal, which is in posteriorly, so that was implanted laparoscopically, that's easier to, for me to remove that with a robot, because that aids me, to be very, very meticulous about, the surgery, about the layers, see very well, all, like it's cellular layers that you can see. So for that, love it. And that's where probably it should be used, but it shouldn't be like used as an elective.
I mean, they're doing gallbladder surgery. robotically. And now mastectomies are being studied for robotics.
Yeah, too much money. Too much money.
I know. I so agree with you. Yeah, we looked at our data of laparoscopic versus robotic mesh removals. The outcomes were exactly the same. We didn't find any benefit. There is slightly more blood loss and vascular injury with laparoscopic than robotic, but it wasn't statistically significant. And I do prefer robotic over that. But during the pandemic, I didn't have access to the robot because the hospitals were shut down to elective care. And so I was doing it laparoscopically in the patients, Also used to doing it robotically, I had to go backwards and do it lap, but it's doable. It's just, I agree with you. I prefer the robot. It's a much daintier operation with a robot. A couple more live questions. You got a lot of live questions today. One is an article reviewing pain management in which David Chen was a senior author, described pain burnout, where basically you have spontaneous pain improvement at about 5 years in a substantial number of patients. What do you think of that? Is that for real? Does the body just give up? I don't know.
I have to admit that, I've read most of the articles that David Chen written. I haven't seen this one, so you caught me here.
That's my audience. They read everything.
Yeah, you told me in the beginning that they're probably more better informed than I am, and that's true here. So, I think it's all in your brain. Like whatever happens to your body and how you feel your body is happening to your brain. And it's all the stimuli that are going. It's neurotransmitters. It can modulate, and we know that, and it can change. And we know about persistent pain cycle. We know about pain connected to trauma, and that persistent pain that is related trauma that happened in the past. So all those things can modulate then and can change. I haven't encountered that in my practice years, probably because I'm not practicing that long to have those patients. But I think probably not spontaneous. Probably if they've seen already David Chen, he definitely did something and did help them. So it might be it's just a longer way for some patients, and after like long-term treatment, the pain just subsides. It's not a one, as I said, it's not the one-off that we do something and it's gone. No. It is a journey.
Yeah, for sure. I mean, I don't know if you've ever had surgery, but I've had surgery before, and the area is not the same. I mean, it could be the perfect surgery and it's still not the same. And then 5 years later, you're like, it's better. Like whatever symptoms you had the first year or 2 or 3, about 5 years, you're just kind of, I don't know if you.
Yeah, our body is incredible. Like, and when we as doctors, we often say that, like we are here only to aid your body, to help you. It's like a robotic surgery is for us. We are for your body, because, in the end, we change something and actually you will heal that. That's why we, for example, we're so, strict about smoking, because when you smoke, you kill your own ability to heal. And that's stupid. You shouldn't be doing that, because how can I help you if you lost that ability? No, you need to have that ability so I can help you. So if I do something, I know that you'll heal it.
That's very true. Dr. Pawlak, does your team ever recommend spinal cord stimulation or dorsal root ganglion stimulation for refractory pain?
Yeah, I've seen that question in Q&As, and I was hoping that maybe we'll skip that. It's another one that I've discussed with my pain specialists. Currently, we are not offering, and my understanding is it's quite invasive as well, and it's a very, very last resort, because it's like it sends like stimulus all the time. So like it's just a mechanical.
Tells your nerves to look the other way, basically.
Yeah,
like, it's here, look that way.
So I'm not talking here from expertise on profound knowledge. I left it with my pain specialists, and they said, like for some really refractory patients, like at the end of the spectrum of we can offer, yes, but most of the patients won't benefit from that. There are other better ways to deal with pain.
Well, I think that's the right answer in the United States, putting in nerve root stimulators and dorsal ganglion, spinal stimulators. It's quite a profitable procedure. And so it's very used, sometimes some can argue overused. I've had patients with a hernia recurrence that went through the whole pain cycle and injections, which of course don't work because you have a hernia. And then they get like pain pills, and then they're put on a trial for this nerve stimulator, which doesn't work. Like, okay, well, we'll put it in you anyway. It's pretty crazy. What we see here with nerve root, like any type of spinal stimulator, etc. Because our pain doctors, I mean, unless they like work with me and they understand me, and I think the beauty of your pain doctors is they understand pain and symptoms related to hernia surgery and hernia repair as opposed to other ways. Like the patients that I see, they will have like ilioinguinal neuralgia, right? Probably due to a small hernia irritating it. And they're told you have to cut the nerve, we have to burn the nerve, we're going to do epidurals, spinal stimulator for like a little hernia, and not understanding that some small hernias can primarily present with ilioinguinal type symptoms, and you don't just wake up one day and have isolated ilioinguinal neuralgia. That doesn't happen unless someone stabbed you there. There's no reason for you to just have that problem. Whereas your patients that come to you and your group, those pain doctors understand surgically what happened, what can happen postoperatively, and correctly don't overuse spinal stimulators. Yeah. Okay.
It's similar with, I think those stimulators are more invasive than surgery, and even with surgery, and I think you mentioned that as well. Sometimes we do something because we really truly believe that it will help.
Yeah.
And some of the patients will come back and will say, no, it might be slightly better, but I still have pain.
Mhm.
And you kill yourself over that. And we are people as well. I had multiple sleepless nights, and trying to find out if maybe I should have done something differently. Maybe I just judged it incorrectly.
Yeah.
But then with time, and again, I'm going back to our bodies. With time, like our body deals with that, because we gave that chance to the body to and reorganize everything how it should be, and it's just taking more time, I think. And again, it's maybe a research. I think the longer some patients had chronic pain, the longer their recovery will be.
Yes. Yeah, true. Here's another question. I have multiple full thickness periosteal sutures as part of a complex groin surgery. Dr. Pawlak, have you ever removed pubic periosteal sutures because you thought they were causing pain?
Yeah, they definitely are causing pain.
Mm-hmm.
Yeah, we know that. And whenever we teach on our courses, where to place stitches, you just don't put them there. You don't put them anywhere close to the bone. So, on the other hand, for example, I deal with complex abdominal wall reconstruction, and we have those complex hernias close to the bony structures.
Yeah.
And you don't have sufficient overlap, and actually you need to fix it to the bone. And we have in our team dedicated trauma surgeon, and trauma surgeons put like all sort of things in the bone.
So there was surgeons,
yeah. And they help us, like they put like stitches through the bone to fix the mesh. And so far from the group that we did, I had only one patient that came back and said, I have complex pain here around that bone. And I don't know if it's from those sutures, it's very, very likely. But his quality of life is quite good, and he's happy with the abdominal wall reconstruction and what he does now. That's his only complaint, like that's but actually, if I compare it to how it was before, it's perfect. I don't want you to touch it. I just want you to know about it, but I don't want you to touch it. And sometimes it is like that. Sometimes we do things that we say we shouldn't do, but we do them for the reason. So again, it's only question of looking at that specific case, what has been done, why it has been done, if that makes sense, what's the quality of life, and what we can achieve by taking those stitches out.
Yeah, I've always wondered this because Parviz Hamid was the first to say, don't put periosteal sutures, part of the chronic pain after open inguinal hernia repair with onlay mesh. And so, yeah, I teach my residents, you put it in the rectus insertion, not into the bone, etc. However, like you mentioned, for posteriorly, like suprapubic hernias, we tack it to the bone. With laparoscopics, you're putting tackers into the bone. It's Cooper's ligament, but it's really you're into the bone too with the tackers. Orthopedic surgeons put sutures in periosteum all the time. So why is this different? I've never been able to answer that question.
Yeah, it's a tricky one. Yeah, it is. I think every case is very individual, and we have to look at everything and what we can offer. And quality of life, that's the end game. If we can improve it, yes, let's do something. If the quality of life is okay, then we should go with that. And that's that's a funny one, because every person, every nation will distinguish different aspects of quality of life that are important. And we discussed that in numerous conferences, that in some cultures there is less chronic pain than in some.
Oh yes,
because of the quality of life. And what is the quality of life, and how it's being perceived.
Listen, India and China are the two largest countries in the world in terms of population, and they have tons of hernia repairs. Not as much mesh-based, but numbers-wise, a lot of mesh-based used. And there are a handful of patients that I get from India, really none from China. And yet in the United States, Canada, UK, Australia, the English-speaking countries, it's a huge problem. I haven't figured that one out either.
Yeah, it's also a huge problem in the United Kingdom, and it's real problem. I see those patients, and I know that it is a problem, and I didn't figure it out that neither. I just discussed it. I remember a funny anecdote on that. I think it was Jorge Diaz. I don't want to put words in his mouth, but yeah. He said, my patients are more focused on fiesta and at like spending their life to the full, drinking wine and just having fun. They don't think about chronic discomfort, pain, and so on. Maybe it's true. Maybe it's it is a process that develops. I don't know.
Maybe they're selling different meshes to the English-speaking countries.
Yeah,
we don't know. So are you part of the NHS system, or it's a different system, and how do people find you?
So I'm a part of NHS system. I'm moving jobs. So actually, very recently, there was a number of publications. If there are any patients from United Kingdom, you probably know that there was a lot of documentaries and articles about mesh, about mesh-related problems, and especially some of those were in Scotland, where I did my fellowship. So we are currently establishing a dedicated abdominal wall reconstruction and hernia center in Scotland, where I will move in September. And yeah, it's NHS based. So if anyone wishes to contact me or see me, I will be happy to see them. Obviously, it will take time now to establish this the service there. So you need to be patient. If you need to see someone now, definitely the team that I was leading in North Devon in southwest of United Kingdom is an excellent team, and you'll find some help, some good help there. And I'm sad to leave, but we developed that service there. It's working perfectly. So in that sense, I'm very proud of it, and I'm leaving it in very good hands of my colleagues. And I'm moving on and trying to establish something similar in Scotland.
That's a really great plan, because Scotland has been on the forefront of addressing patient-related problems with mesh, probably more than any other state, I would say. I mean, more than the United States.
Yeah, and
Australia.
In a sense, I was obviously applied for the job, interviewed, and have the abilities to develop that, but definitely. They were searching for someone who could develop that there, and I'm happy that I got so many recommendations and so many good surgeons and people believing in that, and that it's necessary. And I'm always happy to help.
Yeah, that's really
fantastic. It's Golden Jubilee in Glasgow, where you'll find me starting September.
That's fantastic, and actually. One of the current viewers that's been asking some of the questions is in Scotland, so you may be getting a new patient the minute you open your doors there.
Brilliant.
I'm just here to help,
Yeah, me too. And like I love what I'm doing, and I live for hernia surgery, for abdominal wall reconstruction, and actually, developing knowledge and educating, because I got fantastic education and I love to share it. Yeah. And again, another advertisement, if I may, EHS. If you're a patient looking for any information in Europe, it's EHS, European Hernia Society, that you need to look into. If you're a doctor, you're looking for some knowledge, good courses, learn how to do a proper surgery and so on. Again, European Hernia Society.
Perfect. Sounds amazing. And on that note, we're going to end our session. That was a full hour. Thank you, Maciej. I really appreciate it.
Thank you, Sharon. It was a pleasure.
Thank you. And thank you to everyone who came in live, and a prospective thank you to those of you that are going to be watching this and sharing it and learning from it. And hopefully, if you have any needs, this has helped you get better information and get access to the specialists that you need. Thank you, everyone, for joining me on another great episode of Hernia Talk Live. I will see you again next week with another great guest, and I want to thank you again. You can go sleep now, Maciej. Thank you.
Thank you. Bye-bye.